Much again for joining. We have had over 270 people register for today's webinar from across Canada, which is very exciting and speaks to the passion and interest about this important topic. We would first like to begin with a land acknowledgement. I am currently located on the traditional territory of the Mississaugas, Haudenosaunee, and Anishinaabe within the lands protected by the Dish with One Spoon Wampum Agreement. We have guests joining us from across the country today, so I encourage you all to reflect on the territories upon which you live, work, and play. Today's webinar focuses on advancing best practices for people living with dementia. We're very grateful to Advanced Gerontological Education for sharing their work with us and providing us with tools to improve practice. The excitement and enthusiasm for this session has just been truly overwhelming and speaks to the deep passion and commitment that we all share for improving care for older adults. This is a joint offering representing a partnership between the Regional Geriatric Program Central and the GERAS Center for Aging Research. From a quick housekeeping perspective, we are meeting today via a Zoom webinar. As guests, your cameras and microphones have been muted, but we still do invite you to engage and participate via the Q&A that's in the ribbon at the bottom of your Zoom screen. Also, at the end of today's session, you will receive a survey link requesting your feedback. This survey will just take 2 to 3 minutes of your time and will be so important to help us build future presentations. And with that, I'm thrilled to introduce today's moderator. Lisa Walkup is the Director of Education and Program Development at AGE. She's also a certified GPA master coach and has been part of the GPA cohort of coaches for over 10 years. She is a part-time instructor at the University of Guelph and has been a facilitator with the Interprofessional Education Program at the University of Toronto for almost 10 years. Thank you so much for moderating today's session, Lisa.
Thank you, Jennifer. It's my privilege and honor to introduce our speakers for today. Dr. Victoria McClellan obtained her PhD in psychology at the University of Auckland in 2013 and completed postdoctoral fellowships at the University of Toronto and the Hospital for Sick Children. Victoria's research has focused on memory development, function, and impairment. At AGE, she conducts and collaborates on mixed methodological evaluations of the impact of GPA in healthcare and educational settings, demonstrating how the program improves care and quality of life for people living with dementia and those who care for them. Dr. Laurie Schindel Martin is Professor Emeritus in the Daphne Cockwell School of Nursing at Toronto Metropolitan University, previously Ryerson. She is a mixed methods researcher and advanced practice nurse. Her program of scholarship focuses on the development of theory-driven, competency-based interprofessional education programs that enhance best practices related to dementia behavior, such as reluctance for bathing and sexual expression. Her work includes standardized dementia behavior observation tools to measure impact of non-pharmacological interventions. Thank you, Victoria and Laurie, for being here. I will go on mute and watch the question and answer.
Thank you so much, Lisa. I'm just going to share my screen. Okay, thank you all for joining us today. We're so excited to talk to you about GPA Bathing, which is our new 6-unit online dementia education program in which learners can apply GPA person-centered dementia care approaches within the specific context of bathing. We'll be telling you about our findings from a small-scale implementation of the GPA bathing program within Ontario long-term care homes and sharing the experiences of their staff in providing bathing care, as well as about their perceptions of how bathing care could be improved in their settings. We'll show you the program evaluations that we use to measure the impact of GPA bathing in these long-term care homes and how our findings show how bathing care can be enhanced through education. Now I'll pass it over to Laurie.
Thank you very much, Victoria. It is delightful to be here to talk about this. We are all very passionate about this topic. So what I'm going to underscore here is that for people living with dementia, bathing can be very confusing, disorienting, and overwhelmingly frightening. So this leads to a fear and confusion that is often what we used to call incorporated into a term, resistance to bathing. This person who is being bathed has no understanding of what's about to happen and misunderstands it and can demonstrate protest behavior. And if this escalates during bathing, both the person with dementia and their care provider are at risk of injury. So I state here to put this into context for you from an historical perspective that one case that I'm familiar with was involved bathing going south. To the extent that it went right off the rails. There was a situation where a personal support worker was charged and went to court, and this was in a GTA long-term care home. Simply what happened is the resident lost track of what was happening, stood up in the tub, covered with soapy bubbles. The resident began to scream and swear. The staff member, who was alone, pulled the drain so that the water was going down. Again, thinking very clearly that I can't allow the resident to fall into a tub of water. Unfortunately, charges were laid that may have come from the family, that the resident was still soapy when toweled dry, and the judge's interpretation was that the staff person's inability to continue the bath in that circumstance was incompetence. And this case evoked concerns about many of us because it was really focused on safety and safety concerns. But for those of you who are so interested in this topic, as I think you are, many other modifiable factors were not considered. Again, I state here if bathing is often described in the literature as being mundane, meaning it's everyday, it's simple. It's mundane means you don't have to think about it. You know how to do this so easily when you're bathing yourself. You don't even have to think about it. But we all know that in the dementia context, it's anything but that case. Critical thinking in the moment, in every moment, is required because of the degree of adaptation. I will also say here that research states that even experienced healthcare providers struggle with knowing how best to support people with responsive behavior during bathing. And just as with any life experience that the individual living with dementia has that evokes personal expressions, responsive behaviors, it's the same with bathing. It's not our job, as the judge in the case that I mentioned before stated, to force the individual to continue with the bath to the degree that a family may say the soap bubble should have been rinsed off. We have to make absolute sure that force is not used. And I will say, unfortunately, in the early days of my practice, in the area of responsive behaviors in dementia, it was common to inject droperidol, which is a highly active opioid, through the clothes so that the person was sedated to the extent that there was no protest exhibited. The staff were safe, and the person could be stripped of their clothes and then showered very easily. This is not an acceptable practice and does not align with the concepts of person-centered care. Now, the literature also tells us that education can provide strategies for bathing, but there are very limited existing dementia-specific bathing educational programs. And I will acknowledge here that many of you in today's webinar have developed beautiful programs that take resources, and you have recognized for some time that this education could be for your students, also for new hires in their orientation program, but also continuing education. We're doing these things, recognizing that bathing in dementia is a complex undertaking. I would say that from years of this practice, some of these experiences that I had with droperidol use, etc., were happening in the mid 90s. And we were really struggling with educational resources, and very good descriptive, frequently asked questions documents were being published. And we used these things, we developed slide decks, but despite our individual organizational attempts, bathing challenges continued. To the next slide, please. Uh, um, Thank you, Victoria. So I'm going to say that since 2016, these individuals have been involved with AGE in developing this bathing program that we are going to be presenting today. And these are members of the initial advisory committee. People will also recognize the names of many of these individuals. We have occupational therapists, we have social workers on this team. We have nurses, we have administrators, we have educators, we have specialists, we have a student also who helped us with our comprehensive literature review. So these names are companions of AGE going forward through many years. But guys, these individuals were doing their own bathing education through their roles. So what we tried to do is combine all of our knowledges together, our slide decks, our experiences with teaching, the methods of teaching that we wanted to use. And we oversaw Patricia Julian from Ryerson at that time doing a very comprehensive literature review, gray literature, FAQs, newsletter stuff, articles, and we recognized a big gap, and that is we were not able to find anything that dealt with the deeper challenges, such as the case that I first described. What do you do if the person stands up in the tub, is covered with soap? What are you supposed to do in that kind of situation? How do you use safe interventions to do what you need to do right in the moment, but also then later to readdress some of the continuing bathing and personal care needs that you may not have been able to finish? So we created long tables of the core competencies that the literature, the FAQs, the newsletters, the slide decks revealed. And then we ensured that all of those materials that were built into tables and matrices were used in first iterations of our program. These were tested, and then using that learner feedback, we informed the next stages of the refinement and evaluation, and that is what we're presenting here. Next slide, please, Victoria. So I just want to say here that we know that curricular development is very complicated. And so you need a care delivery framework. You need an educator role framework. You need a philosophy of care, which in our case is person-centered care. You need a curriculum model. You need a learning theory framework. You need a learning objective framework. You need an evaluation cycle. You need an evaluation component looking at Bandura's social learning. In this case, this is self-efficacy. So I'm just going to say that please, when you're developing your own slide deck and doing your own passionate work in your own organization, you often don't have the time, nor do you have the multiple people around the table who can help bring these theoretically plural frameworks to life in the content, which is one of the reasons why curricular development takes so much time. So I also want you to be aware that from a currency perspective, AGE has also been expanding our grounding in theory related to cultural competence and sensitivity, family-centered care, and trauma-informed care. And we gave thought to these newer theories as we were developing the content. Next slide, please, Victoria. Okay, so we have 6 bathing units, and we are working through Lisa's guidance and leadership to create a 7th. More on that later. We're talking right now about the 6 modules. So remember, I discussed that we formed a matrix. What are the core bathing competencies and scenarios, and thus scenarios that we can create based upon evidence and experiential knowledge that will demonstrate those competencies in the content. So we knew we had a foundational unit. We have a shower bath unit, a tub bath unit, a bed bath unit, a spot bath unit, and a team spot bath unit. So these are foundational, they're sequential. The shower bath tends to be now more likely than a tub bath in some of the long-term care homes for ease of access. A bed bath can be used in community across all sectors, also in acute care. Spot bath, in this case, is in a day program. And we have the team spot bath where the team has to collaborate external to the location of the resident to develop a plan for an individual who has stool down the buttocks, back of the legs, and the feet. And how are we going to do a team-based, interpersonal, person-centered, respectful intervention that will deal with the fact that we can't just come back multiple times to see if this gentleman is more receptive, because he will be protesting throughout because he's so afraid and agitated. But we have to clean this person, right? We can't force this person. That is unethical practice. So these 6 units have been clearly identified from a review of the literature. What are those specific types of interventions that will be needed across care sectors, in particular in long-term care homes, complex continuing care, but also in other care sectors? And what are the non-pharmacological, environmental, bathing environment, and the actual act of the bathing? How should they be modified in these types of cases that are transferable to other cases? Each unit is building upon the previous one in terms of complexity and demonstrates with short video clips application to the life history, the bathing history, use of props, visual cues, family involvement to help prevent and de-escalate responsive behaviors. And each unit is done online, takes approximately 45 minutes to complete, and has opportunity for reflection, but also interaction and interactive, self-interactive, and so on. On to the next one, please, Victoria. So I'll just briefly state here that we initially took the first 2 units that had been prepared with infrastructure, reflection, tools that could be downloaded, etc. And we implemented this with 264 of the 4th-year nursing students at TMU, then Ryerson, and 23 behavioral supports staff participants who were educators, clinical specialists, frontline care providers, and they completed a self-efficacy measure with specific bathing activities as part of those measurement points, both pre and post. And we had significant improvement in both of those groups, immediate pre to immediate post. Next slide, please, Victoria. Then we also collected open-ended comments, and I will just say here that the responses to the open-ended questions that were part of the self-efficacy measure, students did some actual wonderful feedback for us. And I see here, Anjali, that there are 2 minutes left if we want 10 minutes of conversation. I don't think we can do this in 2 minutes. So I think the important thing here is for you to understand before students were frightened. They had no concept of themselves as someone who knew anything beyond doing a traditional bed bath, a traditional shower, where the resident is compos mentis and doesn't have any trouble understanding what's happening. Next slide, Victoria. And I will just say that we used these feedbacks of post-intervention. They liked the tools. They liked the introduction of stop and go. They had no idea that they could involve families in such a specific way when they were working with individuals with dementia in healthcare settings. And they also had very specific props and tools and interventions that they didn't understand that they would have before. Over to you, Victoria, who will explain the next stages of some of our work.
Thank you, Laurie. So after these student evaluations, starting in 2023 and 2024, we began a small-scale implementation of GPA bathing in 3 Ontario long-term care homes. So we had a total of 145 staff participants who did the units, and out of those, 121 of them volunteered to complete our program evaluation measures. The analysis that we're reporting here is of the data collected from 47 staff at the first 2 sites, who completed the measures both pre and post. A further analysis of all 3 sites is currently underway. So in this small-scale implementation, we used a mixed methods pre-post design to measure the impact of GPA bathing on staff capacity to provide bathing care. So we collected quantitative and qualitative data on self-efficacy and knowledge in dementia-specific bathing care. And then 6 to 8 weeks after they finished GPA bathing, we invited them to come back and attend an online focus group where they told us about their experiences in implementing what they learned. So for our first evaluations of GPA bathing with the TMU students, we developed a quantitative measure of bathing self-efficacy. This is an adaptation of our previous self-efficacy tool that we had used to evaluate GPA basics. It was a 20-item questionnaire with 7-point rating scales. We asked participants to rate how confident they were that they can achieve best practice person-centered bathing competencies. It also included written open-ended questions about their past experiences and approaches with bathing, their learning needs, and what strategies for responsible behavior they would use in the future. We looked at their qualitative responses. We used a content analysis approach to identify and code the underlying themes, and we chose impactful sample quotes from their responses to represent each theme, and which we'll show you in later slides. So this measure was completed immediately pre and immediately post GPA bathing. They also rated their satisfaction with various aspects of the program on a 10-item satisfaction questionnaire. Then, to measure the impact of GPA bathing on participants' knowledge of person-centered bathing strategies, they did a knowledge questionnaire in which they were presented with bathing scenarios involving responsive behaviors and then asked to choose the most appropriate response. There were 12 multiple choice questions, 2 from each of the 6 units, and this measure was again completed immediately before and after GPA bathing. So we expected that, like in our student evaluations, we would see significant improvements relative to baseline in both self-efficacy and knowledge. So here you can see our demographic data. Most participants in this evaluation were female PSWs in their 30s with college diplomas and who had a wide range of experience working with older adults. So some had only 1 to 2 years of experience and others more than 20. GPA Basics was a prerequisite for participation, and some of the participants had also completed other dementia education programs. These are our quantitative findings. So the graph on the left shows a significant increase in bathing self-efficacy from pre-GPA bathing to immediately after. The graph on the right shows another significant post-intervention increase in their performance on the multiple choice knowledge test. So they felt more confident about their ability to provide bathing care, and they were more likely to choose the correct person-centered approach to situations involving responsive behaviors. The participants were also highly satisfied with the GPA bathing units. They gave mean satisfaction ratings of greater than 6 out of 7 for all components of the questionnaire, including design, content, resources, activities, applicability, and the video case study scenarios. Now, before beginning GPA bathing, we asked the participants about their past experiences in providing bathing support for people living with dementia, and whether they had ever encountered responsive behaviors during bathing. We found that essentially all participants described residents who refused bathing and showed verbal and physical responsive behaviors of risk during bathing. They related these behaviors to the residents' fear, pain, and discomfort. So, for example, residents having unexpected behaviors while bathing, screaming loudly, hitting staff, refusing to go, screaming, yelling, cursing, pushing, punching, and these were very difficult to handle. That was their perception. They also described residents having a fear of water, being in pain, very sensitive to the temperature of the water, and not liking their hair washed or their face shaved or their nails cut. And this last quote describes a resident who is clearly highly fearful of bathing and desperate to get out of the tub. So the resident was screaming, trying to bite, scratch, hit, was throwing water out of the tub at me. She tried to throw the washcloth at me when I started wetting her hair. She was afraid of drowning. She would scream for help and scream that we were trying to kill her while we bathed her. So nearly all participants are describing situations in which residents are extremely distressed during bathing care, and their self-protective responsive behaviors are putting both themselves and the care providers at risk of injury. So we asked participants how these experiences made them feel, and they reported a range of negative emotions, including sadness, disappointment, discomfort, helplessness, fear, and being overwhelmed. So for example, one participant said, "I feel a bit disappointed in myself sometimes because even using the mildest approach and encouraging them to bath seems to not work." So this participant has tried to use basic, calm, gentle communication and found it to be ineffective. They feel like it is their responsibility to know more systematic and effective strategies for bathing. Another participant said, "I feel for them. We are so task-oriented during bathing. We forget how the resident feels. When I see a note stating 4 staff to a bath, it makes me sad." So they know there is something wrong about an approach in which the goal is to complete the bath at any cost, regardless of the resident's feelings or experiences. Similarly, this third participant describes feeling overwhelmed, nervous, and scared. They're doing something wrong to cause the resident to feel so distressed. Another participant describes feeling helpless when their attempts to help residents with bathing don't go well, and they're frightened of someone getting injured. Several participants also mentioned sadness, so they are experiencing moral distress, knowing that it's their attempts to provide bathing care that's creating such a scary experience for the residents. And finally, in this last quote, the participant feels like they've lost control of the situation, they're not capable of doing their job, they're disliked by the person involved, victimized, misunderstood, and at times disappointed or embarrassed. So, overall, these responses show that responsive behaviors during bathing are causing these participants significant distress because they don't feel able to provide effective care. And when we asked them about their learning needs, every participant stated that they require additional strategies and skills for bathing and responsive behaviors. So we asked them what approaches they were currently using for responsive behaviors during bathing. These participants had already completed GPA basics. Many of them were already implementing some person-centered approaches when providing bathing care, including accommodating their preferences, using a slower pace that's reflective of the person's comfort level, validation, preparing the bath beforehand, creating a comfortable environment, and anticipating factors that contribute to responsive behaviors. But given what they told us about their past experiences, we know that there is clearly a need for additional, systematic, evidence-informed strategies that are specific to the bathing process. So immediately after GPA bathing, when we asked what approaches the participants planned to use in the future, they could now name specific strategies and resources that they learned about from the units, including family engagement, documentation of bathing histories, equipment like bathing capes for privacy and thermal bath kits, as well as systems for supporting planned team approaches to difficult situations. And when we met with the participants again 6 to 8 weeks later in our online focus groups, they were able to tell us how they had successfully put these new approaches into practice. So engagement and involvement of family was one of the most frequently mentioned approaches that had yielded a successful outcome. There seemed to be 2 components of this engagement with families, the first being collaborative care planning, and the second being collaborative care delivery. So participants said that they had previously only asked the family very basic questions, hadn't ever gone into depth about bathing processes. They appreciated that they now had a printable resource for documenting this information that they were now getting from families. And they told us that gaining information from one resident's family about her dislike for washing her hair meant that now, instead of yelling and refusing, she was more agreeable to bathing when they let her know beforehand that they wouldn't be washing her hair. Other participants told us how effective it had been to actually involve family members in the bathing process. They hadn't ever thought to do that before. They felt like bathing was their responsibility, that it would be too burdensome to ask family to help when they came to visit. But with one resident, just the act of bringing his wife into the tub room with the team reduced his aggression significantly. So they said, another resident, we've asked the family to come in, really communicating with the team that otherwise were unsuccessful. Working with his wife, because they have that relationship, she's not getting the same aggression from him. Coming in with the teams, just her being there. Pre-GPA bathing, we would have shied away from assisting with their bath when the family was here, and now utilizing the family, asking if you would mind helping us. So this success has made them feel more comfortable about asking family to participate or help with bathing, and with clear positive impacts on the experience for the resident. Participants also found the use of bathing equipment and supplies to be helpful. So they hadn't previously been using bathing capes. They found this additional privacy led to one resident accepting baths when she would have previously refused. They also mentioned that the thermal bath kits were really effective at keeping the towels warm. Previously, they'd been using a basin that would be cold before the bath was complete and could lead to the residents' discomfort. Participants also stated that they were now making more consistent efforts to enhance the bathing environment with things like music. So this first quote, they brought music into the tub rooms, earbuds, and things like that. We were doing it a little on the dementia unit, but now it's more predominant. The other units are getting involved in this process. So these gold standard practices are already being delivered, but education like GPA bathing is required in order for these practices to become consistent across the organization. And finally, participants at both sites conveyed this real sense of relief that they now had education to provide evidence-based and systematic approaches to bathing care. So they could be more confident about being open-minded and adapting bathing care to suit each individual instead of fighting to complete the task in the same way for everyone. They said that this evidence and confidence was leading to greater buy-in across the team, that they can try creative approaches when things aren't working well. So overall, we've shown that within 2 Ontario long-term care homes, bathing had been highly distressing for both people living with dementia and their care providers. But our dementia-specific bathing education for staff has the potential to significantly enhance bathing care in these settings. We've shown that participants were able to successfully apply what they had learned and develop creative bathing approaches tailored to the needs of the individual residents. In their narratives, they told us about how these approaches reduced the likelihood of bath refusal in residents who were previously doing that and reduced their responsive behaviors of risk. So in our future evaluations, we'd like to look at how to explicitly measure rates and intensities of responsive behaviors during bathing and look at whether GPA bathing education impacts these measures. Finally, we want to share our thoughts that there is a shared responsibility between educational institutions and healthcare organizations to disseminate evidence-informed education about dementia-specific bathing practices. So post-secondary programs could incorporate dementia bathing skills to prepare nursing and PSW students with entry to practice competencies before graduation. Healthcare organizations can include bathing education in new hire orientation and annual education programs. In-house educators can use case studies to reinforce best bathing practices during team huddles. And our research has shown that GPA bathing should be disseminated in healthcare settings that care for persons living with dementia. This program will be formally launched and available for enrollment as of tomorrow. While here we've shown that an online-only format was effective at building confidence and knowledge, we also have plans to evaluate the impact of a hybrid or blended online and classroom format in the future as well. Thank you so much for your attention, and we look forward to your questions.
Thank you so much, Victoria, for the wonderful presentation. There's certainly no shortage of excellent content to be shared. So understanding if folks have to leave, if there are other priorities for the day, perhaps we could ask Victoria and Lori to stick around just for 2 or 3 minutes and answer any questions that may have arisen in the chat. So Lisa, I'll hand it over to you.
Thanks, Jennifer. Um, I believe all the answers in the chat have been answered. But if anyone is staying on and does want to put questions into the chat, we're more than happy to answer those. The question of can anyone sign up for GPA bathing? I'm happy to respond to that. Um, uh, Anyone that has participated in the original GPA, so GPA basics, and thank you for those that have asked those questions relative to GPA. That's been very much appreciated. And so you can certainly go to the AGE website and look for information about how to take GPA basics. It is a prerequisite. And I should also mention that what's interesting about GPA, it is part of the Behavioral Supports Ontario 5-star program. So the goal of Behavioral Supports Ontario was to establish and to equip healthcare providers supporting the Behavioral Supports Ontario population with core values, knowledge, skills, and shared language and tools needed to provide comprehensive and person, family, and relationship-centered behavioral health care. And with that, it was very exciting that GPA, it's GPA Basics, GPA is actually one of the STAR programs, the Specialized Training and Resources, along with BSO Foundations, You First, Dementiability, and Pieces. So certainly reach out to AGE for more information. We would love to hear from you. And obviously, we do also want to thank the RGPC and Jairus and McMaster for hosting us today. It's been very, very exciting. Um, and we've got some great feedback, Lori and Victoria, from participants that they're very eager and looking forward to completing the GPA Bathing e-learning program.
Thank you so much, everyone. Thank you to Age and B for being our presenters today. And thank you very much as well for sharing your contact information so that folks may reach out with any further questions. Again, please do take a few minutes to provide your feedback via a survey. And thank you so much for attending, everyone.